So thank you very much for the introduction. I'm going to talk about the detection of treatment-naive CNV in AMD by Swepser's OCTA. So our institute gets research grants from Topcom. Giving you a quick overview. First, I'm going to start with Swepser's OCT and the technique behind it. Then I'm going to talk a little bit about our study, and in the end, some future aspects, which might be very interesting. So what you can see here is the increasing scanning speed rate, the exponential scanning speed rate over the last 2 decades. It all began with OCT 2000 with some size, and we're now at the Triton with over 100,000 A scans per second. So the Plexi light is able to do that. And some prototypes in studies are able to do almost 400,000 A scans per second. Coming to the technique of SD-OCT, of course you all know 840 nanometers wavelength, but it can work on different wavelengths. But what is special about SD-OCT is the spectrometer, which is a line detector and goes afterwards to Fourier analysis. When you have here SSOCT, you have a tunable 1050 nanometer laser, and you have a detector, which is a point detector. The big advantage of Swepser's OCT is it has less sensitivity roll-off. It can go deeper into the tissue. Furthermore, on OCT B-scan, it's possible to penetrate through blood, and it's an invisible scanning light. What you see here is the uniform sensitivity. Everything, the vitreous, the retina, and the choroid can be displayed in one image. When you have SD-OCT, you can either see the choroid, or you can see with EDI, you can see the choroid, or you can see the vitreous. So split spectrum decorrelation. Small video from Topcom. The same position is scanned 4 times. So everything is scanned, the vessel walls, the moving erythrocytes, and what is then performed is a subtraction analysis. So just that the moving blood is then displayed in B-scan and then in an en-face image, enabling you to see the superficial layer, the deep plexus, the other retina, the Schönbein vessel, these are projection artifacts, and the choroid capillaris. Now some studies with SD-OCT and neovascular AMD, they're very heterogeneous sensitivities and specificities. With sensitivity, it means the percentage of CNV detection. Specificity means the percentage where dry AMD is also dry AMD on OCTA. And when we come to Swepser's OCTA and AMD, there are not a lot of studies. So our purpose was to evaluate the sensitivity and specificity of Swepser's OCT in active treatment-naive NAMD. And we compared the Heidelberg Spectralis device, FA and ICG as a gold standard, with Swepser's OCTA. And we enrolled from March 2016 to March 2017. And we had CNV 1 to 3 and mixed type. And exclusion criteria was previous treatments. And by that, we could enroll 156 eyes in 98 patients, and 107 had neovascular AMD. So we used the Topcom Triton device working on 1050 nanometers with 100,000 A scans per second, and we performed 4.4 and 6 millimeter scans. And we did the automated artifact removal optionally, and we did a binary grading, CNV there or not there. So coming to some examples, a 75-year-old male patient, we see some speckled hyperfluorescence in FA, intensifying in late phase. In ICJ, there is a neovascular lesion as well, so we have a CNV1. This CNV1 could be also quite nicely displayed here on Swepser's OCTA, but what we can see here is, of course, the projection artifacts from the superficial layer. So next patient, 73-year-old, you see early leakage, intensifying late FA. So also here, neovascular lesion, quite nicely depictable. And as well on Swepser's OCT angiography, was quite nicely to see. Now here you get some leakage and some speckled hyperfluorescence, intensifying late FA. Here the ICGA, so it's a mixed type lesion. And also here was possible to see this mixed type lesion, the different the different layers and different segmentations. You see the classic and the occult component of it. So now here, 60-year-old, you see some exudate, some hemorrhage. Here's some hotspot, FA. So it's a type 3 lesion, what we have here. And also in OCT angiography, it was possible to see that. But it wasn't always that successful. So a 61-year-old female patient. We see here some speckled hyperfluorescence, some pooling. So as well here in ICJ, there's something detectable. So it's a fibrovascular PAD. And in this case, there was nothing to see. It should be here somewhere. There should be a neovascular lesion, but we could not see it. And you see some projection artifacts here. So we got a sensitivity of 76%. So 81 eyes of 107 eyes could be detected. And on the dry AMD, there was no CNV visible with this Webster's OCTA. So 26 out of 107 eyes could not be detected, and we found some significances, especially when there was a PD over 400 microns, and if there was a CNV1, and both of these informations were statistically significant. So 3/4, almost, or more than 3/4 with of the eyes with active treatment-naive NMD could be detected by Swepser's OCT. 1/3 complicated by CNV1 could not be detected, and 75%, so 9 out of 12 eyes with a PD over 400 microns could not be detected. Here, what you can see here in the bar graphs as well. So again, PD over 400 microns, quite highly chance to not detect. So, concluding that SSOCT was inferior to FA and ICJ for detection of active treatment-naive NMD, and FA and ICJ still remains the gold standard at the moment, and high PD and CNV type 1 are difficult to detect by Swepser's OCTA alone. And nevertheless, it's a very nice and non-invasive and fast detection device, and it should be definitely installed as a first-line addition tool, multi-modal imaging tool. And we published this study in the Retina magazine in 2017. Can have a look if you want. And now some future aspects, because this is possible. This is inside the data. If you do image post-processing, you can get a 3-dimensional aspect of the CNVs, which is very impressive and nicely. So here again an example. What you can see here, the leakage, a mixed type component. Again here, image post-processing, 3-dimensional aspect. So here is the feeder vessel, which does not leak. And here, something like comparable with the tree, the branches, the leaves, they leak. Also here, quite nicely to see. This is not implemented in the instrument. This is done by image post-processing. So again here, patient after 26 injections, you see Schramm here in the OCT, but what's inside Schramm? There is a really fibrotic CNV lesion. And also quite nicely to see here on the 3-dimensional visualization. And apart from that, what is also possible with this data? To fly inside the CNVs. Thank you very much for your attention.